Oh, Morena koutou, tūtoa mai I runga, tūtoa mai I raro, tūtoa mai I roto, tūtoa mai I waho. Kia tau au te Māori tū, te Māori ora ki te katoa, haumie, huie, taike. Tēnā koutou katoa, ko Ben Uden toke ingoa, no irarangi o kutupana, e tipu ake e koe rānana. Ke tamaki makoto e noho ana, no reira. Ka mihi o ki te manga whau, ki te mihi o ki te mana whenua o tēnei wāhi. Ka kore aho I te reo Pākehā. Good morning, everyone. My name is Ben Uden. I'm the director of ASH New Zealand, and also welcome on behalf of their Drug Foundation, who we really want to acknowledge as co-hosts of this morning's webinar. And welcome to everyone who's joining us this morning, and to Professor Anne McNeil and Dr. Debbie Robson, who are joining us on their evening in the UK. I want to just quickly do a little bit of housekeeping before I introduce our speakers today. We have about 45 minutes, and we have 25 minutes to half an hour where Professor McNeil and Dr. Robson will be doing their talk about the UK report on vaping and health. We are recording the webinar, and we hope to make it available after the event, and we will let people know when that happens. We do want to encourage curiosity about this morning's talk, and we do encourage people to ask questions. And if you want to submit those by the chat, they will be moderated just to make sure that we can fit as many in as possible. And we hope to get through as many as we can. But we also ask that you keep questions relevant to the talk and try and keep them clear and concise as well, so that we can answer as many as we possibly can. We also want to acknowledge that there are differing views around vaping, and particularly youth vaping has been a topic which has a very high profile in the media right now and is a very hot topic. However, I just want to remind people that this session is a chance to better understand the UK report, which is often cited as a source of science on the relative risks and harms of vaping. So please take the chance to ask questions about the report. There are forums to debate around vaping, but this is not one. So we really respectfully ask you to treat this as a forum to better understand some of the science and the process behind the UK scientific review. So I'm really delighted to be able to welcome Professor Anne McNeil and Dr. Debbie Robson to speak this morning and give up their evening for us. It is a real treat. They are two incredibly impressive scientists with decades of experience in tobacco control and addictions. Anne and Debbie are two members of a larger team that's worked on the UK evidence update on vaping and health. So I also want to acknowledge that they have a wider team of colleagues who are behind the work that they're presenting today with as well. Anne and Debbie are both based out of King's College London, where they're part of the nicotine research group. Anne is a professor of tobacco addiction, and she has a particular research focus on tobacco control policy and particular interest in reducing health inequalities. Her special interest has been in disparities of smoking in disadvantaged populations, including those with mental health problems. And I also just want to acknowledge her role as the inaugural Vice Dean of Culture, Diversity, Inclusion for the Institute of Psychiatry, Psychology and Neuroscience at King's College. I'm not sure I can do Anne justice, as she must be one of the most published tobacco control researchers in the world, approaching something like 500 publications, and the recipient of several awards, including the WHO's World No Tobacco Award and the Dole Winder Prize from the Society of Research on Nicotine and Tobacco. No less impressive is Dr. Debbie Robson. She's a senior lecturer in tobacco harm reduction at the National Addiction Centre at King's College, and her work has a particular focus on the development and evaluation of tobacco dependence treatment pathways, staff training, and the National Health Service smoking policies in the UK. She's also worked on projects to establish how effective vaping is in helping people from groups who have high smoking prevalence to quit and the harms it causes relative to smoking. She's also a board member of ASH UK. Anne and Debbie have worked together on several of the e-cigarette evidence updates in England, commissioned by Public Health England, and more recently, what is now the Office for Health Improvement and Disparities in the Department of Social and Care. So it really is an absolute privilege to welcome Anne and Debbie, and to hand over to them to talk to us about some of the science behind their report. Thank you.
So thank you very much indeed, Ben, for those very kind words of introduction. I'm going to click on what I hope is our presentation. Yes, thank you very much. So that's the title, and as Ben said, commissioned by the Office for Health Improvement and Disparities, Department of Health and Social Care. So just quickly, we wanted to show our declaration of interests. Ben has given some of our background, but neither of us have received funding from the tobacco industry or e-cigarette manufacturers. So the content of our talk this evening is the context of our review, and then we're going to do methods, results and conclusions, and then pick up on a few methodological issues. And as Ben said, we're part of a larger team working on these reviews, and we particularly want to acknowledge Erica Simonovicius, Leonie Brose and Eve Taylor, who are co-authors of the health chapters we're going to be focusing on. So context. So this is the 6th in a series of government commissioned evidence updates. So the picture here is from the front cover of our 2022 report, but you can see also the previous 5 reports. And as you can see, each one has a slightly different focus. Each year we've been commissioned to examine smoking and vaping patterns in England and then review the international literature on specific topics. So for example, in 2020, we looked at mental health and pregnancy. And then we bring it back together and draw conclusions and implications for the English context. So our 2022 evidence update had 16 chapters and over 1,600 pages. And I've only met one person who actually said they read it from start to finish. But obviously in the 20 minutes or so left for us, we can only really give you a flavour of those middle chapters, which are on the health risks of vaping. We also want to acknowledge a wide group of collaborators, so international experts on certain topics who helped with individual chapters. And then we drew on support and data from a variety of groups. And we had 8 independent reviewers who reviewed the work as well. So this is a very busy slide, but we felt it was important to just say that in England, we do have a comprehensive tobacco control strategy. So that's under the heading tobacco cigarettes. And we also have a fairly comprehensive regulatory structure for e-cigarettes, drawing on the European Union's Tobacco Products Directive. So I won't go through all of these, you'll be pleased to hear, but just picking up packaging there, you can see that we've got standardized packaging, but it's still branded for e-cigarettes. And then tobacco cigarettes, we've got large graphic warnings, but small textual warnings, health warnings on e-cigarettes. And then here in particular, you'll see our notification system for e-cigarettes before they come onto the market, and the quality and technical standards that fall under that. So you can see we have limits on nicotine strength, container size, and tank size, etc. And then the other important context is that our government has announced that they want to go smoke-free by 2030, which means reducing from approximately 14% adult smoking prevalence to 5% or less over the next 6 or 7 years. This was trailed in 2019, and then earlier this year, our health minister gave a speech setting out some of the details behind that. So that's the context. I'll now hand over to Debbie for the methods.
Good evening, everyone. So we had 2 broad aims for the health risk review part of the report. So we wanted to know what effect does vaping have on the risk of getting diseases, and we looked at the big diseases, cancer, respiratory and cardiovascular disease, but we also had a chapter that captured all the other diseases, and we wanted to know amongst people with existing health conditions, what are the effects of vaping on disease progression and outcomes? So we searched and screened papers from August 2017 to July 2021, and our start date in 2017 was based on, we followed on from our 2018 PHE report, which we last looked at health effects then, but also that coincided with the end of the search date for the USA's NASM report, and we pre-registered the protocol. And we compared biomarkers of exposure and potential harm, which I'll say a bit more about in a minute. And we looked at the levels of people who vaped compared to people who smoked, people who vaped with people who didn't smoke a vape, so non-users. We also looked at dual use, but it was so poorly defined across studies. We reported this, but focused on exclusive use in the narrative and meta-analyses, but we do include the data in our tables on dual use. So biomarkers of exposure, that's a measure of a toxicant or its metabolite in the body. And we looked at several different types of biofluids. And then there was one study on hair. And we were guided by the priority toxicant list for tobacco by the World Health Organization. So we looked at nicotine, carbon monoxide, and tobacco-specific nitrosamines, volatile organic compounds and metals, and other potential toxicants such as polycyclic aromatic hydrocarbons. For the biomarkers of potential harm, so that's where you see an effect on the body, so objective medical signs used to measure the effect of a toxicant, a substance on the body, or the presence or progression of disease. And for these, we're informed by the US FDA's sponsored workshop on biomarkers of potential harm for tobacco and nicotine. So we looked at cross-cutting biomarkers, things like inflammation, oxidative stress that cut across major diseases. And we looked at things where they were very simple to measure, like changes in people's blood pressure, white blood cell count and lung function, and things that were quite complex to measure, such as the changes in the way genes are expressed and how it affects our DNA. We're often asked, so, why did you just focus on biomarkers? And biomarkers in humans, they're often used to infer what happens in the future in terms of future disease risk. And this, public health decision-making is frequently made before population harms can be directly assessed through long-term epidemiological studies. And measure an internal exposure to vaping aerosols, tobacco smoke, or early signs of changes in health can generate evidence quickly about short-term but reversible harms. But there's lots of caveats to this, so we need to be able to discriminate from the prior effects of smoking and background environmental exposures. There's still a lot of work to be done around understanding do acute effects translate into chronic effects, and does increased and decreased exposure translate into increased or decreased harm. We didn't include self-reported symptoms except for where studies were assessing people with existing smoking-related diseases, and we defined a priori the length of exposure. So acute studies where there were some studies where people just took a few puffs on a cigarette or an e-cigarette up to 7 days, and then short to medium term exposure was 8 days to 12 months, and then long-term exposures we defined as anything over 12 months. In terms of the results, we ended up with 413 studies that we included in the review. Majority were in humans, but we also included animal and cell studies. But in this presentation, we largely focus on human studies. We created an algorithm for which studies we would select to meta-analyse, and we only meta-analyse human studies. So for exposure studies, we pull data according to the body fluid of a toxicant. So we combined urine with urine studies. We didn't combine urine and saliva studies. And for potential harm, we just pulled data according to the biomarker. So we didn't combine TSNAs with VOCs and PAHs. We just combined TSNAs together and VOCs together. We combined similar study designs, so we didn't combine RCTs with cross-sectional studies, for example. We included studies where they had at least 2 out of 3 comparison groups. We only included studies where they clearly defined smoking and vaping frequency, and it excluded studies where vaping was defined as less than weekly. We looked at studies to meta-analyse where participants were followed up and measured in the groups that they were initially assigned to, and preferably their smoking status, vaping status was bio-verified. And then with regards to the data sources, there's quite a few PATH studies, so US survey studies using the same sample. And we went for the study with the largest sample size when we were extracting data. So we ended up meta-analysing data from 31 studies. So a lot of the same studies come up in the 55 meta-analyses. So here what you can see is there's quite a range of study designs from RCTs to cross-sectional, and the majority of studies, particularly around nicotine, are cross-sectional. And then with the biomarkers and the metabolites, so we looked at nicotine and 4 different metabolites and 4 different tobacco-specific nitrosamines. For the nicotine biomarkers of exposure, there were 60 studies, and there was also 20 pharmacokinetic studies. And for the acute PK studies, what we saw was less exposure from vaping than smoking, whereas the longer people vape and the better and the more experienced they become at vaping, then you can see that people can extract similar levels of nicotine from their e-cigarettes to their tobacco cigarettes. What we saw was higher exposure of nicotine amongst people who use tank and mod vaping devices, but also nicotine salt products. What we didn't see any studies of at the time were the more modern disposable type devices. What we also saw was some compensatory puffing behaviour. So when people were using lower nicotine strength liquids, just like when people trying to reduce tobacco cigarettes, they overcompensate by trying to extract as much nicotine from, say, their 20 cigarettes to when they go down to 10 cigarettes. What you see with low nicotine strengths and vapors is compensatory puffing behaviour. And what that means is that you're taking in more of the aerosol. In terms of flavours are a bit tricky because you've got to try and separate the flavour from the nicotine from the propylene glycol and the vegetable glycerin. So we only found 6 studies in humans, but what we did see was for the biomarkers of exposure, the TSNAs and VOCs, they were significantly reducing people who smoked or dual use and switched to vaping with different flavours. So here we draw on cell and animal studies, and I think there was only possibly about 9 studies. So looking at relative to tobacco smoke, flavours had significantly less effect on cells. So you saw less inflammation and less oxidative stress. Whereas when there was no control group, so looking at absolute harm, there was a small number of studies, and what we were consistently seeing was cinnamaldehyde flavouring was having an effect on cardiovascular and respiratory systems. And that wasn't a new finding. We'd flagged this in our 2018 report, and NASEM had also flagged it the same year. I'm going to hand you back over to Anne now.
Okay, so again, this is quite a busy slide, but here we're showing some illustrative results from the meta-analyses, so this isn't a comprehensive set. So the first column is the metabolites, the toxicants, and then the second column is showing vaping versus smoking, in other words, the relative risk of vaping versus smoking. And the third column, vaping versus non-use, so the absolute risk from vaping. So in the second column, you can see quite a lot of downward green arrows, meaning that the toxicant was significantly lower in the bodies of vapors than it was in the bodies of smokers, suggesting that the risk of vaping was lower than that of smoking. You can also see some equal signs. In the final column, you can see some red arrows, upward arrows, which means that the toxicant was significantly higher in the bodies of vapors compared with those people who neither vaped nor smoked. And again, you can also see some equal signs. Some of these findings were perhaps a little bit unexpected, but when we drill down, so for example, with these tobacco-specific nitrosamines, they shouldn't really be found in the bodies of people who are vaping, unless there were some impurities in the process of making the e-liquid, because these are tobacco-specific and therefore they're not, and e-cigarettes don't contain tobacco. When we drilled down a bit further into these, we saw that where there had been a long interval after someone had stopped smoking, then the tobacco-specific nitrosamines were very similar to non-users. And this is because the half-lives of tobacco-specific nitrosamines vary. Some are quite long. So you have to make sure there's an adequate washout period when somebody stops smoking before you look at the nitrosamines in their bodies. Also, you can see there's some equal signs in both columns, suggesting the same level of the in this case VOC, in vapors, people who vape, people who smoke, and then people who do neither. And again, looking at these in a bit more detail, some of these compounds are caused by environmental exposures or caused by dietary exposures. So you have to take account of those background exposures when you're trying to isolate the effects of smoking and vaping on people. That was just a backup slide in case that one got messed up. But when we looked at the biomarkers of exposure to toxicants which were related to the specific diseases, and we look at the three big diseases, which are the three main killers of smoking, so that's cancer, respiratory disease, and cardiovascular disease, you can see that the levels of toxicants were significantly lower consistently for the three diseases for when you compare vaping versus smoking. For vaping versus non-use, they were largely similar. So the levels in people who are vaping were similar to those who don't smoke or vape, but in some cases they were higher for some, as we've seen. So moving on to biomarkers of potential harm, and this is just a similar diagram table to the one that Debbie showed earlier for biomarkers of exposure, showing the variety of designs and then the different types of biomarkers that we were looking at. And again, a lot of cross-sectional studies, and the longitudinal studies were mainly acute, very short-term exposure. Now, this area of research, biomarkers of potential harm, is a relatively new area. It's a growing literature. For example, I think there were 2 studies in the NASM report, and then we had around 40 odd in ours. And there was a lot of heterogeneity across the studies, so it's much more difficult to synthesize the studies. And so in this slide, we're trying to summarize a lot of data in a little time. But for cancers, we basically saw that vaping is not having the same effect, or didn't appear to be having the same effect on cells as smoking. So there was a non or a less pronounced effect, but there was in a few cases higher. But a really interesting novel area of research is developing on methylation and demethylation of specific genes, which looks like it will be potentially useful for looking at DNA changes in vapors versus smokers, for example. For respiratory diseases, just looking at spirometry, so acute, we saw largely no significant difference in lung function between people who vaped, smoked, or sham vaping control arm. Perhaps mirroring that you do see some symptoms in people who are vaping as well as smoking in the short term. But as people have been vaping for longer, so people who switch from smoking to vaping, for 3 months there was no change in spirometry measures. In 2 years, you started to see some declines, but these were not significant declines in the complete switchers. But unfortunately, in this particular study, there was no control group to compare with. And then for one of the longer studies, which we've put here as 3.5-year follow-up, we saw similar lung function between people who were vaping and then a matched group of non-users. For cardiovascular diseases, we've just chosen heart rate and blood pressure. And in acute studies, the changes were either lower than or similar to smoking. But in the longer term, what we were seeing was they were similar to non-users. But as we've said, there were a shortage really of very long-term studies. But although the evidence then is more limited for biomarkers of potential harm, we saw no really major causes of concern regarding vaping harm to health in the acute and short to medium term. And we contrast that with a study which we think was a little bit unethical because it switched people who had smoked and then were vaping, it switched them back to smoking for 7 days. And you did see some significant increases in lung function for a few of the measures. And we didn't see anything like that in the vaping studies. I'm now going to hand it back to Debbie for second-hand exposure.
So we didn't find many of these studies. We only found 6 studies overall, 2 of which exposed people to atypically high levels of vaping admission. So there was one study where they looked at people who were in a vaping convention for 6 hours, or stuck a few people in a room with 3 vapors and the vape most of the day. For biomarkers exposure, so that looked at tobacco-specific nitrosamines and a few volatile organic compounds, so I think acrolein. And what you saw was acute second-hand exposure to vaping aerosol resulted in non-significant changes, but with longer exposure associated with increases. But in a lot of the studies, the levels were below the limit of detection for tobacco-specific nitrosamines and VOCs. And then for potential harm, there was just a couple of the studies with serious risk of bias. So it was difficult to draw any conclusions with this. So this is definitely an area where there needs to be more research. We had a big chapter on fires, poisons and explosions, and each of them can be very serious, but fortunately they're rare. So we drew on data from the UK's National Poisons Information Service. So we've got 4 national poisons services. We looked at their 2021 data, and they told us that they had 40,000 telephone inquiries about poisonings generally, and about 0.5% of those inquiries were about vaping products. It was largely people accidentally swallowing e-liquid, and a lot of them were children under the age of 5. We had, because we were focused on UK, we also looked at case reports in the medical literature, and there was a couple of reports of intentional poisoning with e-liquids from the UK, with one unfortunate death. And then there was studies outside of the UK where in the literature there was about up to 16 intentional deaths recorded. In terms of explosions, so incidents of exploding batteries are obviously very serious, but fortunately very rare. We looked at 50 published studies of case reports, case series from burns and surveillance centres, and that included about 3,000 cases. And again, a couple of reports of non-fatal accidents in the UK, and then one report of one fatal accident in the US. We sent a Freedom of Information request to the London Fire Brigade and asked them how many call-outs there'd been to cigarette-related fires and vaping product-related fires between 2017 and 2021. And they told us that over 5,000 cigarette fires, where cigarette fires was the cause, it was the ignition source, compared with 15 fires as a result of vaping products, with no injuries or fatalities related to the vaping product related fires. But you can see over 600 injuries and unfortunately 46 fatalities. So to conclude, so based on the evidence that we reviewed, what we said was in the short and medium term, vaping poses a small fraction of the risk of smoking, but it's not risk-free, particularly for people who've never smoked. But the evidence was mostly limited to short and medium term effects, and studies assessing longer term vaping, so more than 12 months, are necessary. But we need more standardized and consistent methodologies in future studies, because that's going to help us improve the interpretation of the evidence.
And so just the final couple of slides on the implications. So here we come back to the England context as we were drawing these together, drawing on the wider evidence base on risk perceptions. So we did a systematic review on what affects risk perceptions and whether that influences behaviour, and then drawing on wider evidence on smoking cessation. So just looking at risk perceptions very quickly, the green line is the correct answer, that vaping is less harmful than regular cigarettes, and it's been going down over recent years. It's now around a third of, and this is adults who smoke, so these are people who would benefit from stopping smoking and potentially switching to vaping if that helps them to stop smoking. And it's only around a third who are getting the correct answer. And then in relation to aids used in the most recent attempt to quit smoking, data from colleagues' smoking toolkit study at the University College London shows that really when vapes entered the market in England around 2011, they very quickly became the most popular aid used in quit attempts and have stayed that way. And at first there was no it wasn't as a result of health professionals or anyone, and they were doing that of their own accord. So we wanted to try to capitalize on that to ensure they're as successful as possible. So we've also reviewed evidence looking at population studies and our smoking cessation services, and then also drawing on the Cochrane review, where there's quite a consistent picture that e-cigarettes are effective at helping people to stop smoking. So our messages, Debbie's shown the sort of conclusions, but our messages for those people who are smoking, who've never tried vaping or have tried but continue to smoke, is to try vaping to stop smoking and completely stop smoking. Just because of the unique harmfulness of smoking, we're trying to underscore that with this message. And then for people who've never smoked, we say, please don't start vaping. Vaping won't be risk-free. And don't start smoking either if you've never smoked. So I think that was our final slide. Oh no, the standard. Yes. So just from chapter 16, we've mentioned throughout this presentation that there were there's lots of heterogeneity in the research, which is such a shame because there's an enormous amount of research going on around the globe on vaping, but it's so heterogeneous we can't really synthesize it. So we're suggesting, and we've been talking to a few of the international experts who've been supporting us and others about having a vaping standard. And I won't go into all of these, but just things like ensuring that people who say they are vaping exclusively are, and if we're trying to quickly identify health risks, then we want people who are vaping frequently and exclusively. And then looking at what are the most informative biomarkers that are clinically relevant that we should be using. So if this is an area of interest, then do please get in touch with us. So thank you very much. Thank you for listening, and we're very happy to answer any questions.
Oh, kia ora, Anne and Debbie. So I think we've got some questions coming in, but there's one I wanted to kick off, and I want to abuse my privilege as the host to ask it. And that is sort of having done this work looking at huge amounts of evidence around vaping. Moving forward, what gaps do you think there are in the evidence, and what future research would you prioritise?
What I prioritise would be longitudinal studies. I think, as many of you know, the British Doctor study was really informative in terms of identifying the health risks of smoking. And it's unfortunate that we haven't got major ongoing cohort studies in this area. So for in England, vapes have been around for 10, 12 years, and we could have collected a lot more long-term data than we have. Also, we think that we didn't talk about it, but people who vape who've got smoking related diseases, we might see some impact sooner. And again, we found very few of those studies ongoing.
Well, thank you. And we've got a question from the comments as well from Kim. Is there evidence that people who quit smoking by using vaping to do so also quit vaping eventually?
That's a good question as well, Kim.
I think there is, but so certainly anecdotally we know this, and I'm wondering, does the smoking toolkit study that UCL
have data
they look at it? Yeah. So I off the top of my head, I don't know the actual proportion of people that do that, but I'm thinking of Peter Hayek's study, so in Queen Mary's University. So he did a randomized control trial where he randomized people to either have an e-cigarette starter kit and 4 weeks of e-liquid or combination nicotine replacement therapy, and it was set within smoking cessation services in the UK. And quit rates were 18% in the e-cigarette arm and 9% in the NRT arm. But when they looked at people kind of a year later, 80% of people were still vaping. So, you know, people do continue to vape long term, but in some ways that might be a positive thing because it'll prevent people relapsing back to smoking.
And that's certainly a message that health professionals have been giving out. Don't try to stop vaping until you're confident that you won't relapse to smoking. We are aware that there is some research growing research on vaping cessation as well, which will be useful in this regard.
Well, thank you. And I know we've just had some of our researchers here in Auckland have just been given a grant to look at vaping cessation as well. So we're kind of look forward to seeing what comes of that as well.
Yeah, good luck with that.
Yeah.
Important study to do.
Something I also wanted to ask about. Something we hear a lot is that we don't know what the long-term effects are of vaping, and they still remain unknown. And I would be really interested in your thoughts on this, I guess, both from the perspective of, is there anything we can tell from the last 10, 15 years of data around vaping? And also from what you've looked at in the science review, what do you think we can say about the sort of potential long-term risks? What should our messages be around that?
Yeah, I mean, the longest study I think we looked at was 5 years, the COPD study, where it was 2 years retrospective and then 3 years prospective. So we do need long-term studies, and there are some more that have come out recently. There's some coming out of the PATH study, for example. I think we can't say anything about the long-term effects, because the biomarkers that we are looking at are steps on the way to disease outcomes. So obviously exposure doesn't translate through to risk, but you're getting some idea of the level of circulating toxicants in the body. And then, as we said, with biomarkers of potential harm, you're starting to see changes in the body which could be predictive of disease. So I don't think we would say that they're completely unknown, but obviously we are keen to see many more studies looking over time, and we've got randomized controlled trials which have followed up people for 1 or 2 years, where it wouldn't cost much more to follow them up for years after the studies have finished. So it's disappointing that there isn't more research going on in this area.
So we probably have to look at modeling studies that can kind of predict harm. So Ken Warner's team in the US, I think, have done a couple of modeling studies that looked at different scenarios, different kind of prevalences of vaping. And I think one of the earlier studies found that it was any kind of relative to smoking, it's kind of 5% to 20% of the risk of smoking.
Great, thank you. And we've got a question from Ruth Benita. So I noticed you don't use the 95% or less harmful statement. Why is this? So I believe this was the estimate of relative harm by the group led by David Nutt some years ago. And in the initial Public Health England reports, you talked about it as being a way to communicate relative risk, but it's certainly become, although it still gets sort of used out there in the wider world, it's become less prominent in the report. I wonder if you could talk to us a bit about that.
Yes, definitely. Yes, so we did draw on this. It wasn't just from the Nutt report. That there had been other analyses done by colleagues in the UK, Robert West and others. And then we also looked at what was in e-liquids and then what was in the emissions, and converging around the 95% reduction estimate was a useful tool, as we say, to communicate relative risks. Having said that, it wasn't that easy to understand. And in fact, the RCP did its own analyses a year or so later and came out with the 5% or less of the risk of smoking, which was better because it didn't suggest a sort of point estimate. So yes, we reported that in the 2015-2018 report. I think the amount of research has increased over the years, but also the heterogeneity of the vaping market has increased rapidly. And so we felt that it was probably more useful to converge on this fraction of a risk statement that we've used in the latest report rather than the 95%.
Great, thank you. And so we've got a question from Scott about some of the biomarker research. Did the biomarker research quantify and monitor trends in vaping-related lung surgery interventions?
Vaping-related lung surgery interventions. I'm not quite sure.
So yeah, so perhaps Scott, I don't know if you could elaborate in the comments a bit.
About Valley, are you, Scott, by any chance?
Oh, quite possibly, yes.
We didn't look at EVALI in our research. As you know, the CDC have concluded that that's largely down to contamination of vitamin E acetate. So we didn't look at that, if that's what you were getting at.
In cannabis vaping, yeah, not nicotine vaping.
Yeah, that's probably an important clarification, is that a lot of the reported cases in the US were concluded to be products which are contaminated with other things as well. So one thing I also wanted to ask about is the young people, because there's also a lot of quite often confusing research out there around gateway and young people who never smoked vaping, and is there a gateway effect? Were you able to look at that at all in your review of the evidence around young people?
So in our first report, actually, we touched on the gateway, but we concluded it wasn't a terribly useful theory because it was not really testable, because you can't randomize youth to different environments. But we haven't looked at it in our more recent reports, because there is a Cochrane review going on in this area at the moment, which is in the write-up stage. So we, as we did with the smoking cessation and e-cigarettes, we've sort of deferred to them. Certainly in England, in 11 to 15-year-olds, using the surveys that underpin the government's monitoring, smoking and smoking rates have gone down to the lowest level, while vaping has been increasing. But we know that in other surveys, the data are showing slightly different trends, particularly in older youth, and particularly more recent. That's slightly complicated by COVID, but we have seen some increases in smoking. But I think we would defer to the Cochrane review, which is doing a very thorough analysis of looking at initiation of vaping and smoking.
Great, thank you. And I think we've probably got time for one more question. And I see Ruth Benitez just asked one more on the same topic around young people, and because it's just been such a topical issue here as well. So Ruth says, whilst I appreciate the webinars about adult risks, could you say anything about the risks to developing brains?
This isn't something that we sort of found research on, but there is a massive study going, I think it's the ABC study or something, going on in the US looking at this area of research. I mean, a lot of people say that nicotine is damaging to the developing brain, and what we would say, well, if that was the case, then there'd be an awful lot of brain damaged people who, in 50 years ago, I think there was 80% of men in England were smoking, and most of those would have started in adolescence. So there would have been a lot of brain damage as a result of that. So I think sometimes these things are bandied around, but the evidence for them is a bit thin on the ground.
And they largely come from animal studies as well, kind of adolescent mice, rat studies.
Yeah, and we don't know how generalizable they will be to humans.
Yes, great. Well, look, thank you very much, Anne and Debbie. And I see the comments have started to warm up just as we've run out of time. But Debbie, I will hold you to sending you any questions that come afterwards, and hopefully hopefully we can ask even more of you to find some time to give us some answers to those. But I want to very much thank Anne and Debbie for taking time out of their evening to talk to us about the report and answer questions for us. It's been a real privilege to have you talk to us, and thank you everyone for participating. So I know we're at 9:15, and I know everybody's got to get on with work. So if I'll close off the meeting. Tu e kirunga, tu e kiraro, tu e kiroto, tu e kiwaho, tu ki te heri tangata, ka rango te po, ka rango te ao, tahi e Maori ora. Thank you very much, everyone.
Thank you very much for inviting us.